Hello. Today's review is on sulfonylureas and meglitinides. I will give you an overview of sulfonylureas first, then we'll discuss meglitinides. Back in 1942, a researcher called Jean Bon and his colleagues discovered that some sulfonamides cause hypoglycemia in experimental animals. This accidental discovery led to the first clinically useful sulfonylurea, a drug called carbutamide, but it was withdrawn from the market because it adversely affected bone marrow. However, this paved the way for the synthesis of the first and second generation sulfonylureas. The first generation sulfonylureas include tolbutamide, acetohexamide, tolazamide, and chlorpropamide. These are no longer being used because they have a higher prevalence of hypoglycemia and risk of causing cardiovascular events compared to second generation sulfonylureas. Second generation sulfonylureas include glyburide, glipizide, glimepiride, and glycoside. Glycoside is not available in the US, so we will focus on the three second generations that are available for use in the US. Now let's get into the clinical pharmacology of sulfonylureas. Sulfonylureas are what we call secretagogues. They exert their therapeutic effect by binding to receptors on the pancreatic beta cells that stimulate the release of insulin. Before initiating a sulfonylurea, you should order a C-peptide test to see if the patient is still producing insulin. Proinsulin which is made in the pancreas, is a precursor for insulin. It is a molecular chain containing insulin and C-peptide. When the C-peptide is cleaved off, then insulin remains. The amount of C-peptide is directly proportional to the amount of insulin, which makes the C-peptide test a great predictor of endogenous insulin. Sulfonylureas are indicated for type 2 diabetes as monotherapy or adjunctive therapy. However, they are contraindicated in patients with type 1 diabetes. Pregnant and nursing mothers should discontinue sulfonylureas as they can cause severe hypoglycemia in neonates. Sulfonylureas may be ineffective due to primary failure or secondary failure. Primary failure is when the patient fails to have an initial therapeutic response to the sulfonylurea, while secondary failure occurs with disease progression or with chronic use of sulfonylureas. It is believed that chronic use causes the downregulation of pancreatic beta cell receptors to which the sulfonylureas bind. With fewer receptors available, sulfonylureas lose their efficacy. So when the pancreas stops producing insulin and the patient starts receiving exogenous insulin, the sulfonylurea should be discontinued. Now let's discuss pharmacokinetics. The second generation sulfonylureas have distinct pharmacokinetic profiles. However, they are all absorbed from the gastrointestinal tract. They have different onsets of action, half-lives, which is the time it takes for half of the drug to be removed from the body, and durations of action. This is important to know because these can help you determine which sulfonylurea is right for your patient. For instance, the onset of action of glyburide occurs within 1 hour. It has a half-life of about 10 hours and its duration of action is roughly 24 hours. This would not be a good choice for someone who is predisposed to hypoglycemia, such as patients with hepatic or renal disease. However, glimepiride exerts its effect within 1 hour with peak effect in 2 to 3 hours, and its half-life is about 5 to 9 hours and lasts about 24 hours. whereas glipizide is absorbed rapidly and completely and exerts its peak effect within 1 to 3 hours. And it has a shorter half-life than glyburide and glimepiride. Its half-life is about 2 to 4 hours, and it lasts about 12 to 24 hours. This is an excellent option for patients who are hepatically and renally impaired. All sulfonylureas are metabolized in the liver, but glyburide and glimepiride both have active metabolites, while glipizide has no active metabolites. Active metabolites, if they are strong enough, may prolong the hypoglycemic effect of sulfonylureas. So knowing the pharmacokinetic profile is important. So glyburide has a weak active metabolite, which has negligible hypoglycemic effects, while glimepiride has active metabolites that have about 1/3 the effect of the parent drug. So all three sulfonylureas are mostly excreted in the urine and feces. Sulfonylureas are usually dosed once or twice daily, 30 minutes before a meal. The main benefits of sulfonylureas are they are inexpensive, they're effective, they yield about a 1.5 percentage point decrease in A1C. However, they have side effects. The main side effects are weight gain and hypoglycemia. They can also increase the risk of having a cardiovascular event, and other side effects include hemolytic anemia, which can occur in patients with glucose 6-phosphate dehydrogenase deficiency. Therefore, sulfonylureas should not be given to patients with this condition. So just to recap, there are 3 sulfonylureas available for use in the United States. They are indicated for type 2 diabetes. They work by secreting insulin from the pancreas. Based on their pharmacokinetic profile, glipizide is the least likely of the 3 to cause hypoglycemia because it has the shortest duration of action and half-life compared to the others. The benefits include efficacy and cost effectiveness. The primary side effects are weight gain and hypoglycemia. They may cause cardiovascular events and hemolytic anemia, so they should be avoided in patients at risk for this condition. Now let's discuss meglitinides. Meglitinides are another type of insulin secretagogue. There are 2 drugs in this class, repaglinide and nitaglynide. In 1997, repaglinide was the first meglitinide to hit the market, and then nitaglynide was approved in the year 2000. Meglitinides work similarly to sulfonylureas in that they stimulate the release of insulin from the pancreatic beta cells. However, they have a different binding site on the beta cell receptors than sulfonylureas do. They are short-acting oral tablets that are usually taken 3 times daily just before meals to cover the postprandial rise in glucose. They are indicated for type 2 diabetes and can be used as monotherapy, but mostly as adjunctive therapy, and are usually given adjunctively with metformin or thiazolidine diones. They are contraindicated in patients with type 2 diabetes and in patients taking gemfibrozil. So that's something to be aware of. And of course, those that have hypersensitivity to meglitinides. Now let's discuss the pharmacokinetics of meglitinides. They both absorb rapidly from the gastrointestinal tract. Repaglinide, its peak effect occurs within 1 hour, while the nitaglynide peak effect occurs in 1.5 hours. But they both have a half-life of 1 hour and are both metabolized in the liver. They are also excreted in the urine and feces. The benefits of meglitinides includes their short acting and effective. They yield about a 1.5 percentage point reduction in A1C, similar to sulfonylureas. However, they can cause hypoglycemia, so they should not be taken when meals are omitted, and they should be used cautiously in patients with severe renal disease. So now to recap, there are two drugs in the meglitinide class, repaglinide and nataglinide. They work by secreting insulin from the pancreas. They are indicated for type 2 diabetes. They are short-acting and are dosed 3 times daily before meals. They are effective at lowering A1C. Side effects include hypoglycemia, so used cautiously in special populations such as those with renal and hepatic disease. This concludes our review of sulfonylureas and meglitinides. Thank you and see you soon.